Hey everyone, in today's lesson I will discuss about aspiration syndromes. Aspiration of material that is foreign to the lower airway produces a varied clinical spectrum ranging from a symptomatic condition to acute life-threatening event. Overall, this condition is called aspiration syndromes. Specifically in this lesson, I will discuss the most common cause of aspiration syndromes, that is aspiration of gastric contents. Aspiration of substantial amount of gastric contents typically occur in the context of vomiting. This vomiting is common in the case of general anesthesia, gastroenteritis, and altered level of consciousness. So aspiration of gastric contents is most common during those things. Pathophysiologic consequence can vary depending primarily on the pH, volume of the aspirate, and the amount of particulate material in that aspirate. Increased clinical severity is noted with volumes greater than approximately 0.8 ml per kg and the pH less than 2.5. So if the aspirated gastric content is more than 0.8 ml per kg and the pH of that aspirate is less than 2.5, it can cause severe aspiration syndromes. After massive aspiration of gastric content, hypoxemia, hemorrhagic pneumonitis, atelectasis, intravascular fluid shifts can occur, and also pulmonary edema all occur rapidly. Most clinical changes are present within minutes to 1 hour after aspiration event. In the next 24 to 48 hours, there is marked increase in lung parenchymal neutrophilic infiltration, mucosal sloughing, and alveolar consolidation that often correlates with increasing infiltrates on chest radiographs. Infection usually does not have a role in initial lung injury after aspiration of gastric contents. But aspiration may impair pulmonary defenses, predisposing the patient to secondary bacterial pneumonia. In a patient who has shown clinical improvement but then demonstrates clinical worsening, especially with fever and leukocytosis, secondary bacterial pneumonia should be suspected. Regarding treatment, in a patient who had already an artificial airway in place, it is important to perform immediate suctioning of the airway. If immediate suctioning cannot be performed, lateral suctioning or bronchoscopy is usually of limited therapeutic value, except when there is suspicion of significant particulate aspiration. Attempts at acid neutralization are not warranted because acid is rapidly neutralized by the respiratory epithelium. Patients in whom large volume or toxic aspiration is suspected should be observed, and they should undergo oxygen measurement by oximetry or blood gas analysis and a chest radiograph even if they are asymptomatic. If the chest radiograph findings and the oxygen saturation are normal and the patient remains asymptomatic, home observation is adequate. For patients who present with abnormal finding or in whom the findings develop during observation, oxygen therapy is given to correct hypoxemia. Endotracheal intubation and the mechanical ventilation are often necessary for more severe cases, and the bronchodilators may be tried, although they are usually of limited benefits. There is no prophylactic corticosteroid and antibiotics as initial intervention, but we can give antibiotics if there is secondary infection. A mortality rate of less than or equal to 5% is seen if 3 or fewer lobes are involved. So, mortality rate is less if there is few lobes involved, and it is more if more lobes of the lung are involved. Unless complications develop, such as infections or barotrauma, most patients recover in 2 to 3 weeks. Prolonged lung damage may persist, including scarring, bronchiolitis obliterans, and bronchiectasis. Regarding prevention, always we should have to prevent aspiration of gastric content as much as possible. When airway manipulation is necessary for intubation or other invasive procedures, feeding with enteral tubes passed beyond the pylorus is always mandatory. Elevating the head of the bed 30 to 45 degrees in mechanically ventilated patients and oral decontamination reduce the incidence of aspiration in ICU patients. Minimizing the use of sedation, monitoring for gastric residuals, and the gastric acid separation will all help prevent aspiration. Preoperative restriction of oral fluids to otherwise normal children for 6 hours does not appear to provide benefit compared to restriction for only 2 hours. in terms of the risk of aspiration. So for otherwise healthy children who is going to undergo surgical procedures, 2 hours of fluid restriction of food and the fluid restriction is adequate to prevent aspiration. This is all what I have. Thank you for watching.